Thank you very much. It's a pleasure to have you all here in my living room tonight. I know it's a little tight in space, but we'll make do. I hope you all are faring well and finding ways to not only be productive, but to find some sort of growth and engagement in the world at this time. So welcome. So I'm just going to share my screen so that you can see my PowerPoints because they're much prettier than I am. And so today, the title of this talk was Bioethicist Talks About COVID-19. If you do have questions, you can put them into the chat box. And sometimes people, will have time for questions at the end, but sometimes people are like, oh, I had a question, but I forgot it. If you put it in the chat box, that way you don't have to worry about remembering it, it's there. All right, so my background and experience area, it really started about a decade ago when I was a professor at the University of Texas in San Antonio at the medical school there. And this was when H1N1 pandemic was going around. And I got asked to lead that program for the medical center, as well as got brought onto the state task force dealing with the guidance for the pandemic flu plan. In 2009, the Institute of Medicine, which is now the Academy of Medicine, really started asking jurisdictions, states, cities, universities to start planning for what they called crisis standards of care. That we've known that at some point there was going to be a large infectious disease. This is not a unique thing in human history. We've always been dealing with pandemics. There's a great history of the plague literature, and quarantine is actually about a 600-year-old concept in modern times, and it goes back thousands of years. The first plague actually is, the first quarantines talked about almost 3,000 years ago. So we knew eventually this would happen, and we have dealt with SARS, and we have dealt with MERS, and we have dealt with H1N1, and so these are experiences that we have had. So the Institute of Medicine decided it was time for us in the United States to start thinking about this, start some planning. So I worked with the state of Texas. I also was brought into Brooklyn, the borough in New York City, and we did some exercises with them. Most recently, for the last 5 years, I was the chair of the ethics subcommittee of the Illinois Crisis Standards Task Force and a member of the leadership committee for that, which ironically had to cancel its final meeting in May because we were all busy actually dealing with a pandemic rather than celebrating completing 5 years worth of work. And now I serve on the DePaul COVID response task force. We meet several days a week and talk about, we were involved with the decisions of how do we keep our community safe? And that's really our priority. So I think we just should acknowledge where we are in the world right now. We are, as of about an hour ago, there are 1.4 million cases of COVID in the United States and 4.4 in the world. Note that we are 4.5% of the world's population, and we have, almost 30% of the cases in the world. As far as deaths, we have had 85,000 deaths in the United States, and there are about 3,100 in the world, not the word, the world. In Chicago itself, we've had 33,000 cases with about 1,500 deaths. What's interesting is that we've been collecting a lot of information in the city about the age of people when they die, their race, if they have other health conditions, and this is not something the feds are recording. They actually are staying away from it for some reason. But as you can see in this screen, there are, basically people over 30, over 18 are really being hit. Kids are not getting the initial problems, the severity with the disease, but they are getting related diseases now, and I'll talk about that in a bit. But you can see, like, once you hit 40, the rate really kind of increases dramatically as part of the percent of the population. The death rate is highest for people who are over age 70 and goes even higher over age 80, but it does affect people at almost all ages. Interesting thing about this disease, it affects men more than women. We don't know why yet. Still working that out. And it affects Blacks and Latinos more than it affects other groups. This is probably not related to any biological susceptibility, but to existing disparities in the health infrastructure, lack of care, higher rates of chronic disease than we see in other populations. And the majority of people who are dying from COVID have underlying chronic health conditions. Lots of times lung issues, diabetes seems to be an issue, kidney disease also seems to be a factor. So that if you have a COVID infection and another disease, that seems to be an indicator that you're more likely to have a more difficult course of the disease and more likely death. It doesn't mean you can't die if you don't have those. It just increases the chance that you will have a more severe situation. So this is, as a bioethicist, I work on this every day. I'm teaching my classes. This has obviously become a huge part of every class that I teach. And I'm also part of a group in the city of bioethics people that are working from the different institutions to share our protocols, our programs, our concerns. We're working on educating the public through events like this, through writing op-eds in the newspapers and putting on webinars for the larger public. We're talking to the media, doing expert interviews, that sort of thing. One of the questions I'm going to pose later is actually one that a journalist posed to me this morning. But this kind of gives you an idea of the different types of things that we in bioethics are working on. So crisis standards, and I'll touch on a lot of these in greater detail. So the crisis standards of care is an important piece. We are looking at scarcity of resources. This is what you've heard a lot about. Do we have enough ventilators? Do we have enough beds? Do we have enough drugs? What about the flattening the curve? So we'll go into that in greater detail. The economics. This is a huge ethical issue about keeping people at home versus allowing the economy open and people to be able to go into public. Like, these are big issues. The recovery planning, we're also working on some of these issues for that. Like, how do you mitigate the harm that could happen if we open too soon or too fast? Research. So there is a ton of research going on. I'll talk about that in a little bit. And how do we do that safely? How do we do that effectively? There is so much misinformation and so much poor research going on that's sort of muddling the scientific waters that we have to be really careful about how we do this well. We have to protect our healthcare workers. The rates of infection and even death among healthcare workers are very high. And so this is something that we're concerned about. How do we protect them? Social disparities. As I said, the death rates in Chicago area and being reflected in a lot of states are very high among people of color. Those are social disparities that we need to think about because they can be reflected in a lot of our planning. And then the question of personal actions. What can I personally do to help keep people safe, to help see us through this period of history that we are in? Okay, so the crisis standards of care. This was the piece that the Institute of Medicine kind of initiated a decade ago for everybody to do. The city of Chicago did this fairly early on. The state was a little late, but we've been working together and in conjunction since 2014. And what this means is it's different triggers for when we should be thinking about the providing of medical care and the need for public health services at different times. So in conventional times, this is normal. This was life back in January. This is when, if you need health care and you can afford it or you have health insurance, you go to your doctor and you get it. Right? This is, you can go and get your regular physical, you can get your teeth cleaned, you can have screenings. This is normal times. Excuse me. The contingent is the middle piece. In contingent, this is where we were in March. Some would argue we should have been there earlier, but we were basically here in March. And this is, we know that the disaster is coming. We know that there is going to be a problem with resources, that we don't have enough of whatever it might be. This is where you started hearing about flattening the curve. This is where you started hearing businesses close and states close down, because we knew we needed to hold on to what we had, the resources we had, to take care of the disaster when it hit. And so this is when you stop elective medical procedures. And then you have the crisis, which was when you are in the middle of it. And crisis is really defined as the system is overwhelmed. The need far outweighs the capacity that we have. In the contingent stage, we built surge capacity. So our normal ICUs can handle a few thousand people in the state of Illinois. But what we needed was for way more than that. And so what we did was we took other spaces in the hospital and we converted them into ICU rooms, so recovery rooms. We used pediatric ICUs and put adults in them. We built out all of McCormick Place so that in case we needed the space. It turns out we haven't at this point needed the space. We had extra ICU space. So we created the surge capacity. So in crisis, you're using the surge capacity and perhaps even coming to its limits. And the surge capacity, the ability to build out the surge capacity fast is really what has prevented things from being worse than they are. An important thing to know about good planning and good public health is that when it works, you don't notice it. There aren't more deaths because public health worked. There aren't more people being infected because public health has worked. And as bad as this situation is, it could have been a lot worse if we didn't act as we did. Now, from an ethics standpoint, this little colorful framework, when we are in each of these stages, we have to go about making decisions a little differently. So when we're in conventional times, we're in this blue area, and we use our traditional biomedical ethics frameworks. We put an emphasis on the patient and on doing what's best for the patient. In the surge times, we're sort of moving away from that and questioning, well, do you need this surgery now? Could this wait a while? And we're sort of adopting more of a population perspective. And then in the crisis, we're fully into looking at a population's perspective where we put the community first. So the way these differences look is that in conventional times, we're focusing on the needs and the choices of the individual patient. This is what we call autonomy, right? That you get to self-govern. You get to make the choices of your own healthcare. And you, assuming you have good insurance or you have the money, can get access to those services that you need, right? We ask the question, what does the patient need and what does the patient want? Our focus is on curing and treating an individual patient. When we move into this crisis mode, when we go looking more into public health ethics, the focus moves from the individual to the community. So this is where you hear about, this is why we're talking about numbers of cases and deaths so much more than you would normally hear for the numbers of cancers in a year or the number of people with diagnosed with diabetes in a year, right? Because we're taking more of this public health perspective. And our concern is now we're in a time of scarcity. There's not everything that we need. How do we fairly distribute these resources that people need to get healthcare, to stay healthy, to treat the disease? And the focus isn't on what does each patient need, but how do we reduce the morbidity and mortality for the community? Right, so we're focusing more on the numbers of the community and on what we can do to keep them healthier and from dying. And we're kind of getting this balance of the needs of the society against the rights of the individual. So most of us here in Illinois are at home. But our rights as individuals are that we should be able to go out and do things that we want to, when we want to. And so we're balancing this right. And this is a really important part of what we're doing. So here's some more stats. So you can see, I don't know if you can see my cursor, but the dark gray section is our normal number of ICU beds in the city, which is about 700. Sorry, I was wrong when I said thousands. It's about 700. And this blue line is the number of beds that are occupied by people with COVID. The red line are the number of ICU beds used, period. So you can see that COVID basically doubled the number of people in ICU beds in Chicago. The light gray is the surge capacity. That's what we built by using other parts of hospitals, by putting tents in front of hospitals, by converting McCormick Center. And the whole flattening the curve thing was about keeping us below overwhelming the system. So originally below the number of ICU beds we would need, which is this gray. Now clearly, fairly early on, early April, we went, actually, end of March, we went well above that number, but we've been able to create the surge capacity. So this is a good thing. We have not gone above, we've gotten close, but we haven't gone above that yet. The problem is if we open up too soon and infection starts spreading, we could easily overwhelm the system because that's not a lot of space. As far as ventilators, that was the other thing you probably heard a lot about. You can see that these are the number of ventilators that have been in use for different things. This is our normal, the number, so this is the number of ventilators used by COVID patients, the little dots. The dark gray is the total number of ventilators that we're using. You can see it's almost between a third and a half. And then the gray are the number of ventilators we have available. There's no data in here, that's why there's that block. So we've done pretty well with ventilators, in part because we're using fewer ventilators in treating patients. It turns out that a COVID patient who goes on the ventilator is unlikely to come off the ventilator. Some studies are showing the death rate on ventilators is as high as 80%. So we are using ways to get oxygen, to oxygenate our patients without the force. So using CPAP machines, which you might be familiar if somebody has sleep apnea, that are more gentle on putting oxygen into the lungs. As well as doing things like just turning people upside down and then tilting so that their head is down helps clear out a lot of the congestion in the lungs, and that helps improve their oxygenation rates, so you don't necessarily need ventilators as much. So we've been finding creative ways to deal with this. So the question is, when we do have this scarcity, how do we distribute things? Well, we could look at potentially what are the chances of survival, right? What are the chances that a particular patient is likely to survive? And there are algorithms for this. One is called SOFA, and it's a formula that is supposed to predict what the chances are a person to survive the disease. They're very imperfect instruments. We use them, but they're not great. We could look at the social value. So one of the things that we've considered is, if somebody is a first responder or a healthcare provider and they get sick because of the work they're doing, should they get access to a hospital bed before somebody who doesn't? Like, do we owe them that for the risk they took to serve us in society? Or their social roles. Should we give us, if an elected official, a governor or a president became ill, should we give them a space? Should they go to the head of the line? Those are kinds of decisions. We could also choose that we're gonna do first come, first serve. So the first person who shows up to the hospital gets the bed. When we're out of beds, nobody gets then that's it. Boy, there were typos in here. Sorry, I was just putting this together this afternoon. The problem here is, though, it encourages people to show up as soon as possible to the hospital, and that can overwhelm the system fairly quickly. We could maximize the number of lives saved. So we could say we want to keep as many people alive and going as possible. But this might mean that we're taking a lot of people who, say, have another disease, and maybe they only had 6 months to live before COVID happened. And now that we're going to treat them, they'll still live, but they'll only live for a month, right? So lives saved is, again, an imperfect distributor. We could look at maximizing the total number of lives saved. So should we save, so that of all the people we save, we should have the most life years available to us. This tends to benefit younger people who would have more life years in front of them. So a 70-year-old person might have 10 to 20 years ahead of them, whereas a 30-year-old person probably has 50 to 60 years ahead of them. We could talk about maximizing quality of life. The person who is not only likely to recover and survive, but will be able to contribute back to society, will be able to live a full quality life, however you want to define that. This, however, has the effect of being biased against people with disabilities or different abilities. We could choose to do life cycle, that everybody should have an opportunity to live a full life cycle. So this would say that people who are older, who have already lived a good chunk of their life, are not prioritized, and will prioritize people who are younger that haven't had an opportunity to have all the experiences of life. We could also make this just random, that we have a lottery. Everybody gets a lottery number, we call a number, and that's the person who gets the ventilator or the ICU. So these are the kinds of things that we think about. These are the sorts of scenarios we play out, and we look at what the positives and the negatives, the benefits and the risks are for each one of these, and we apply these, and we talk to the public health, and we talk to doctors, and we talk to administrators about this. Health disparities are huge. When we started our work with the Illinois Task Force, one of the first things we said was, in a pandemic, in a crisis, disparities are really going to become noticeable, but they're also not a time when we can cure a disparity, right? So we know that most of the deaths are to people of color, to nursing home residents, people who are immunocompromised, no matter their age. We're not going to solve that problem because this is years and years, decades of lack of infrastructure, lack of access, chronic disease burdens on these communities that we're not going to be able to fix right now, but we should think about prioritizing for future fixing. There's also a lot of discrimination going on. We've had elected officials on the federal level talking about this is a Chinese virus, and that has led to hate crimes against Asian Americans. That a lot of these allocation systems, as I described, can discriminate against people who are seniors or have different abilities. And so we need to be sure that we are aware of and we avoid discriminating against people just because of a characteristic or that they belong to a population that has absolutely no relation to the disease. Even in teaching, we've found a lot of these disparities. So with about 48 hours notice, all of DePaul classes went online. It was Wednesday evening, and I was told Saturday that by Saturday, my final exams for winter quarter were going online. So it turns out not everybody has a powerful computer. The reason that you have to see my back wall instead of a lovely Zoom background is because my 2016 MacBook doesn't have enough power to actually put a background on this. So not everybody has a powerful enough computer. We were also discovering not all students have high-speed internet at home. Chicago Public Schools has found they've lost 20% of the students. Those students just haven't logged on. Nobody knows where they are. So there are disparities even in being sheltering and working from home. Not everybody has the option of working from home. I'm very fortunate. I can teach my classes from home. I can give lectures from home. That's a very lucky thing. But there's a lot of people who don't have that luck. People who are essential workers, our direct healthcare providers, are the people who are picking up the garbage and janitorial services and keeping the electric grid going and picking up the garbage. I mean, these are people that we rely on, and they don't have this option of staying at home. So that's a disparity that we have to think about. Okay, so I mentioned earlier that there are a lot of research issues we want to think about. This is a snapshot from about 4 p.m. of ongoing research regarding COVID in the world. So as you can see, there are almost 1,100 trials, clinical trials going on that are registered. There we have, you can see that 23 of those are for hydrochloroquine, and a lot of the studies that have been done on that drug have shown it's actually incredibly dangerous and have stopped the trials. It can cause a lot of heart arrhythmias and cardiac disease that's long-term, and so a lot of those have been stopped. But you can see for different diseases, also for different conditions, the inverting the body and putting the head down, that is also being done as a trial. You can see one for traditional Oriental medicine, different sorts of things that people are trying that are being done all over the world. One of the things that has been raised that's interesting is a challenge trial. So there's something like 100, I think there's 104 vaccine trials going on throughout the world, and 4 in the United States. When you give somebody a potential vaccine, what you're doing is you're injecting this and you're hoping it works. And over a long period of time, you're comparing the population of people who got your experimental vaccine with a population that did not. And what you want to see is that your experimental population has a lower level of new infections than in the other population. And that's really how we know the difference. So a challenge trial, which has been purported, because those sorts of clinical trials take time. And time is something that people don't feel they have right now. How long can we reasonably live the way we're living? So a challenge trial is we give somebody that vaccine, we wait a couple of weeks till they would mount immune response, and then we expose them to COVID. So this is deliberately exposing somebody to the infectious agent. Very problematic throughout our research history. The closest analogy is probably the Guatemala syphilis studies of the mid-1940s, where the United States government hired prostitutes to try and give syphilis to prisoners in Guatemala. And very problematic. We have apologized to the Guatemalan people for this, and we have made some reparations, but it is exposing healthy people to a disease that we know causes severe morbidity and mortality. It causes death, and it can cause some long-term health problems that we're still learning about. And so there are some ethical issues about this. Like, can you even, there's 14,000 volunteers. There's a list, 14,000 people have signed up to do these trials. But if we don't even know what the risks are, can they really give their consent if they truly don't, if we don't know to say, these are the bad things that could happen to you? There's also a problem, as I mentioned, about the quality of a lot of this research. So some of it are just small trials, case studies that people are doing. They get hold of a drug and they're just trying it. And we've seen this over and over. So the hydrochloroquine is a good example of this. It was a small study done in France in one institution. And that trial actually was pulled because it turned out that anybody who got sick while they were on the drug got removed from being counted towards the study. So 6 people ended up dying, but their numbers were just removed, so we didn't count those. That's problematic. You have to count everything on a trial. And so because of the poor quality of what was done, and it led to a misleading conclusion. And so everybody, this has been espoused at the highest levels, that this is the treatment. And it was based on a flawed study that has disproven. And actually a lot of the studies on hydrochloroquine since have been stopped because of the danger it causes, the risk of heart damage. So we have to think about those things. There's also a lot of issues we've been talking about with reopening. The questions about how soon, how fast. As you may have known, as of last night, Wisconsin is now wide open. There was a judge's order, a lawsuit by some members of their legislature, and the Supreme Court of Wisconsin last night said that the governor could not actually order the shutdown, renew the order of the shutdown, and so they're wide open. So you can technically go there and do anything you want. We'll get to that question in a second. Well, to really open up safely, we need to be able to test people, and we need to be able to trace their contacts. So if you were in the same space as somebody who had the vaccine, who had COVID, we need to be able to know that so we can get those people to isolate. This is important because right now, everybody's sheltering in place. This is not the hammer, this is the boulder, right? This is the huge, we're just gonna get everybody down. But to be able to open up more, we need to be able to use finer and finer tools. And so testing and tracing is important for that. One of the proposed ways to do this has been creation of apps. Apple and Google are working on this. And so it's an app that if you have your phone, you might get a notice at some point, hey, you were at this place at this time, and somebody who was diagnosed with COVID was there, you should self-isolate, contact your doctor, call them. But those apps mean they have to have access to your phone, to your logging data, where you are, when you were. So those privacy issues are a really big thing. And then when we're through this, once we've given away that privacy, can we get it back? So that's an issue. Another proposal that's been put forth are called immunity passports. And so if there is a vaccine and you've had the vaccine or you have survived the virus, that you would get this passport and you would be able to kind of go out and navigate the world. And those who did not have the disease yet would stay at home and sheltering. Clearly, you can see this creates 2 classes of people. People who can go get a job and go out and do things, and the rest of us sort of are stuck at home. And there's a lot of implications for that, a few of them positive, treating people differently in this way. It also could encourage people to want to go out and get infected so that they can get their passport, and so we could see more spikes happening. And then we have to really deal with the fact that there is so much misinformation out there, so much fake news, to use that term, but so much misinformation. And some of it is unintentional. People read something, it's interesting, they repost it, they send it on their social media feed without checking it. And that has come to people believing a lot of things that simply aren't supported by the data at this time. So please check your sources, please use good sources, please think if you're going to share something that it comes from a good reputable place and that it's proper information. And I try to do that, and I've had like 2 or 3 posts that somebody's come back to me and be like, yeah, actually that's been disproven. So then I go and I take it off and I just let everybody know, hey, made a mistake, sorry about that. So we really have to be responsible with how we educate and inform one another. That's very, very important. So what can we do? I mean, all of this are sort of system level things. We can, they're what public health deals with, they're what our healthcare providers deal with, they're huge system level things. What can you and I as everyday people do? Well, we have a saying in ethics that just because it's legal doesn't mean it's right. And so even if your state opens up, I would encourage you to stay at home as much as possible. If you can work from home, work from home. Because flattening the curve simply it doesn't mean that the disease is gone. It simply means that we are hoping to space out the need for hospital services so we don't overwhelm the system, so that we enter that very severe crisis standard of care situation. So staying at home is good. If you do venture out, I have a dog, I gotta walk my dog every day, I have to get groceries every couple of weeks, wear a mask. And the mask is not to protect you, it is to protect everybody else. And you're like, but I'm not sick. Here's the interesting thing with this virus, is there are a lot of asymptomatic carriers. That means people who are infected, who are shedding the virus, but are fine. There are also a lot of pre-symptomatic people. So we know that people are shedding the virus, that means kind of sharing it. Sharing is often a good thing, not in this case, but people are sharing the virus before they have any symptoms. So you might start running a fever on a Wednesday, but that means you've been shedding the virus since Monday or Sunday. And how many people have you exposed at that point? Wash your hands often, frequently, 20 minutes. If you don't have access to, not 20 minutes, 20 seconds. We'd be in a drought if we did 20 minutes, my apologies. And if you don't have access to clean water and soap, then hand sanitizer is a good second choice. Put off what you can. If you are feeling a need to go out, to go to a service, think about, do I really need this to survive? I mean, we were talking before this started, I really want a Stan's Donuts, and they're actually open. Will I survive without a Stan's Donuts? Yeah. So it's not in my neighborhood, I'm not gonna go. Is there another way to get it? Can I order it? Can I do pickup? Can I do curbside pickup? Those sorts of things. And then for your medical procedures, if it's elective, if it's a non-essential, like a routine health visit, you're healthy, and you're like, well, it's time for my physical or time for a teeth cleaning. Like, if you don't need it, you might want to consider putting that off. And if you're not sure, you can call your healthcare provider and see what they think. Also, we need to be together on this. You need to check on your vulnerable neighbors and your family members, especially, so many people in nursing homes now, there's no visitors. There's no visitors in hospitals. People are in hospital and they have no visitors. So phone calls, Zoom, FaceTime, these are good ways that we can connect and be social, because it's physical distancing, not social distancing, physical distancing. We really need each other right now. Okay, so these are a couple of questions I wanted to offer. They may answer some of the questions you have asked, but they are also some of the questions that I get frequently. So my drugstore has N95 masks. Should I buy them? They'll protect me, whereas the other masks don't. And my answer is no. This is why the original information we got was not to wear masks, because we want to preserve the medical grade masks, the surgical masks, the N95 masks for our healthcare providers and our first responders. They're the ones out on the front line. They're the ones we need to protect, because if we don't have them, we're really not going to get through this. For us, homemade ones, you can buy ones online, Etsy, your neighbors may make them. Heavy duty cotton, quilting cotton is the best, but if all you have is a t-shirt, double or triple fold it, make a mask. There are lots of patterns for sewing and non-sewing online. And again, the medical grade masks are about protecting the healthcare provider from getting the virus from a patient. The masks that we're walking around in are about protecting other people from the infection we might have. I live in a state, I told you I was going to get to this. I live in a state that's opening. Is it okay to do my shopping or eat out in a restaurant in that state? Well, here's the thing. Viruses don't know how to read maps. They just don't do it terribly well. So if you are going to go, ask yourself the same questions. Do I really need this? Will I survive? You can see without a haircut, you're not going to feel or look your best, but will I survive without it? Absolutely. If you do go, make sure you isolate for 2 weeks beforehand, so that if you are carrying the virus, you don't bring it with you to this other state and these other people. If you do go, wear a mask. Do not take the mask off. Wash your hands, put your mask on. Don't touch the mask till you get back home. Wash your hands frequently. When you get back home, change your clothes in the garage, the foyer, in front of the front door, put them immediately in the laundry, put something else on. Make sure, because we just want to be sure we are doing our best to prevent any transmission. You might make the choice. You have the freedom to choose to go do these things. We have not closed states down. You have the freedom to do this stuff. But the people, when you return, the people that you come in contact with, your roommates, your family, turns out maybe pets, the grocery store clerk, when you go to the grocery, they didn't make the choice to expose themselves. But because they're now seeing you and you made that choice, you're kind of forcing the choice you made on them. So that's something to consider and think about. Again, we're not in we're not in conventional times where we're thinking about individuals. We're in crisis and contingency where we're thinking about others in the public community. Can I have friends over for a visit? I have a new neighbor in my apartment building. She's having friends over. I can hear them. But here's the thing. People have to have isolated for 2 weeks before they should go consider visiting someone else. Are you sure your friends coming over have actually done that? If you do, wear masks. Make sure everybody washes their hands when they come in, when they leave. You might even want to have gowns. Remember the changing the clothes as soon as you come back? Well, maybe you want to have like a surgical gown, or tell people, or have some robes or something that people would wear while they're there, and then go right into lunch when they leave. Make sure you stay 6 feet away from each other at all times, even in the space. Do you want them using your bathroom? If you only have one bathroom, and make sure you clean that before and afterwards. If you want to share a drink or food, make sure they bring their own, because and you shouldn't touch that, because if they come in and they've brought a bottle of wine and you touch it and it's been exposed to virus, it can transfer to you, so you got to wipe it down. You have to have your own stuff. And then after their visit, all of you all need to isolate for 2 weeks to make sure that you then don't distribute it to others. So the answer is maybe, but there's a lot of steps we have to take to do that. I'm on day 61. It's not easy, I can say that. Should I share the elevator with other people? So I encountered this yesterday. I was on the elevator in my building, and it's not huge. And I'm on the 7th floor. It stopped at the 6th floor, and somebody was going to get on. And I was a couple, and I said and they did not have masks on. And I said, if you are going to get on, please move aside so I can get off. I'll walk the one flight. I don't mind that. And then they decided, they kind of blocked it and let me go, and then they stepped back. You have to decide what your willingness to risk is, and I feel that for me, masks, and I don't necessarily want another person in the elevator. It doesn't mean I have to wait for an elevator. Sometimes there's a line to get into the elevator. Again, 6 feet apart while you're waiting. And we actually got a note from the apartment building this morning that's saying only one person or one group who live together should be in the elevator at any one time. So, in short, no. If you can avoid it, please do not. Should I go to my local eatery, a local restaurant, and get takeout or curbside pickup? And yes, let's support our local businesses. When we're through this and we want to come back to our communities, we want them to be vibrant. We want to be able to go to the places that we always enjoyed. So please consider doing pickup and takeout rather than dining in. Even in places that have opened, they're at 25 or 50%, so you might not be able to get in. Pickup and takeout helps support the restaurant, but also minimizes the risk. I choose to do pickup myself because I feel like delivery is asking somebody to take on the risk for me. And when I bring it home, again, I have sort of a space by my front door. I set a towel down, I put the food down, I take my wipes, I wipe the containers down, I let everything dry. And so just do all that. And it seems silly, but it's all about keeping us safe. What about schools and camps? This is something DePaul is considering right now. Like, when are we coming back in the fall? We don't have an answer yet, is the honest truth. But what about summer camps and things like that? And unfortunately, the answer is we don't know. The feds have given us a 3-phase plan. Illinois itself is a 5-phase plan. We're in phase 2. Schools and camps are phase 4. The earliest we could potentially get to phase 4 is the end of June. And Chicago has its own 5-phase plan that's even stricter than the Illinois one. And so it might be longer than that. In fact, most of our summer programs and concerts have been canceled. We've got questions for the future. Like, we don't know. That's why bioethics people are really busy right now, because we just don't know. If we do develop a vaccine, and there's no guarantee we will, there's lots of diseases we never have created a vaccine for. How do we distribute it? Donald Trump recently said that he would use the military to distribute the vaccine. I don't know if that means, we sit people down at gunpoint who say, I don't want a vaccine, and force them to take it. These are questions. It turns out the anti-vaccine movement is really gearing up to get people not to take a COVID vaccine. So that's a lot of where this misinformation is happening. But as you can see in this piece from Nature, this is already starting. There's already an information campaign to get people not to take a vaccine that doesn't even exist yet. How long can we reasonably stay closed or living in small spaces by ourselves? And then what are the future implications? There's a wonderful series in The Atlantic that's looking at like how our world will change as a result of this in our healthcare systems, in architecture. Like, the big open spaces have been the thing in homes, but if you've got, two parents and two kids at home, you may not want to all be in the same room all the time. It might be nice to have spaces. Having foyers, they might come back because we want a space of transition. Flying is going to be very, very different for us. Shopping is going to be very different. And will socializing look different? These are all things we just don't know yet, but we're thinking about. How do we go about this? And then again, what we don't know is almost more than what we do know. We don't know all the ways that this virus can spread. We don't know if there will be a vaccine. We don't know if there will be an effective treatment. We don't know if this is kind of it. That's very unlikely. Or if there will be multiple waves. A lot of the countries in Asia are starting to see second waves. Italy and France and Germany are starting to see second waves. And then what are the long-term health consequences to being exposed to the virus? Even for people who recover, even for those who have gotten off ventilators and left the hospitals, we are finding a lot of blood clotting disorders related for those people, that they have a very high rate of strokes and clotting disorders. Children who have been exposed to the virus are now coming down with something like Kawasaki disease. And so they have rashes. It's very dangerous for children. There have been over 100 cases in the United States. And all we know is that they all seem to have COVID antibodies, but we don't, from weeks and weeks earlier, but we really don't know how this works or what the connection is. So there's a lot that we don't know about the long-term consequences of getting this disease. So when people say, oh, I'm just gonna go get the disease, get my passport, be done with it, it's not that simple, because there could be lifetime chronic illnesses that are a result of having this that we don't even understand or know about yet. That's kind of everything I had prepared for you. I wanted you to have the list for the corona counter so that you could see the deaths and the cases from all over the world, the Hopkins piece I showed you. And this is about the clinical trials. And here's information on how to contact and reach me. But now we are open for questions. I'm going to stop sharing.
Awesome. Well, thank you so much. I mean, not only was that very educational, but I know certainly I have some personal takeaways as well to think about. We had some great questions submitted through the chat throughout your presentation. And if anybody has any additional questions, again, please feel free to submit them through the chat now, and we'll start to review those as well. Some of the questions came up early, but then you touched on, but I want to make sure that we address some of the nuances in the questions as well. One specifically was that in terms of visiting immediate family members, they asked, does it matter if they live nearby? And one part of that question was, what are your thoughts on visiting someone outdoors, like meeting for a picnic, or if that changes any of your recommendations at all?
Sure. So I think if you are going to meet with somebody, outdoors is better than indoors. There's more air, sunlight is great, but you still need to maintain that minimum of 6 feet. So if you want to go on a picnic, 2 separate blankets, bring your own food, kind of scream over the distance. But yeah, I mean, that's clearly, we are social creatures. We need some social interaction, but still remember that 6 feet has to be honored, and wear a mask. I'd say that's also really, really important. Some of the studies show that the virus can actually travel up to 13 feet. So 6 is kind of a minimum guideline. But yeah, I mean, I have a colleague who's a physician. She's invited me to her backyard, which she has set up as a visiting area with 12 feet between the chairs. And there's a bottle of wipes when you get into the gate, and you wash your hands and you wipe down your chair yourself, and you sit there and bring your own stuff with you. So yes, I think that's doable, but you still have to maintain those distancing guidelines. That doesn't change.
Great.
Is there another part of that?
I think you touched on most of it. If you have any follow-up questions to the ones that I'm asking, please feel free to chat them in the chat. One question was, from a bioethical perspective, is it possible that there will be more harm done, particularly to poor and minorities, or poor populations and minority populations, from the economic shutdown than from the pandemic itself?
Could you read that one more time?
Yeah, absolutely. So from a bioethical perspective, is it possible that there will be more harm done specifically to poor populations and minority populations by the shutdown than by the pandemic itself?
So that is a common question. The way I see it is harm as in terms of like job loss and financial loss and maybe not being able to pay your rent and things like that versus death. So whatever harms there are, we can deal with. We're a dynamic, creative society, and the alternative is death. So I think, one is we have to be creative and think and figure out ways to finance. The other is we bury a lot more people. So I think from a bioethical standpoint, it's what's the value of a life?
Thank you. And I saw you just shared some of those resources again in the chat. For everybody, we also can share those and the post-event email as well in case you're interested in following up. One of the early questions, again, I think you touched on most of this, but if you could maybe expand, it says you probably will cover what you did, but they're really curious about the ethics of vaccine testing on people prior to typical safety and efficacy preliminary work. Part of the questions being specific to remdesivir. Yes.
So that's not a vaccine. That's a drug. It's an antiviral drug. It's not. So that's an interesting one. So hydrochloroquine was approved by the FDA for certain conditions like lupus, right? There are people who use it. And when the word came out that this was being pushed forward, suddenly people who needed it for conditions that it was approved couldn't get access to it anymore. And that was problematic for them. So the other, remdesivir isn't currently approved for anything, well, until this week. And now it was in trials. The way the trial system works is we do it first in animals to make sure that it's safe in them. And then we do a phase 1 trial, which is a very small number of people, like 20 or 30, to make sure it's safe, to make sure nobody dies, nobody gets too sick. And then in phase 2, we do a larger group to see if there's anything going on. And it's phase 3 trial where we'll do like 1,000 people. And phase 1 is healthy people. We're just trying to see if it's safe. Phase 2 and 3, we use people who have that condition. So we have to get enough people with that condition to be able to do it. That's pretty important. So remdesivir at this point, it is very hard to get. So one of those scarcity things, because it wasn't approved for anything, there wasn't a whole lot of it around. And now they have to ramp up production and there's just not a lot available. So that's going to be one of the limitations for there. But we're still working on, so it's preliminarily approved, but we're going to keep collecting data on it to see what the effect is. Another one that I saw in the chat box that I can answer is, what is a DNAR? So DNAR is do not attempt resuscitation. You may know this is a DNR. So one of the things that some hospitals have done is, we know that this disease, one of the things we know is that it spreads from mucus, from the mucus in your lungs and in your nose. And when you're doing CPR on somebody and you're forcing air into their lungs and you're intubating them and you're doing chest compressions, it forces out those particles of mucus. And that's where the virus likes to be. And so it is a very high risk procedure to do that for a healthcare provider. And we also know that somebody with COVID is very, very unlikely to be resuscitated. And so is the small chance of success worth the risk of infecting the healthcare team? And so some hospitals have said no, and they're like, our policy is not to do this on patients with COVID. The hospital I work with has not said that, but many hospitals have. And so this is a discussion because, again, it's about protecting those healthcare providers. Okay, either I have frozen or Emily has frozen. I'm not sure which. Okay, I'm still getting new messages. Thank you. I appreciate that. Okay, so I'll just go through the list. Is it wise to visit a national park? Absolutely. Being outdoors, getting some exercise is great. However, the national parks are going to limit the number of people they let in. Some of the state parks in Illinois have opened, and it's okay to go there as well. But be prepared. If there's a lot of people on a trail, you might not want to take that trail. You want to be sure that, again, the social distancing piece, spacing yourself, that's really important. I would still wear a mask unless I was in the back country and I was the only person there, because I would still have that mask on and I would still maintain the social distance. I think that's really important. And also, like, be aware of touching things. So if there's a map underneath the glass of the different trail system and you touch that glass, you don't know who else has touched that. So you've got to kind of keep that in mind. But yes, if you can get away from people, that's a great thing. Let's see what else we got there. So as many as 150,000 people die due to the economic shutdown from suicide, domestic violence, failure to treat. How do we balance value those lives with COVID lives lost? So, you know, we've hit 85,000 COVID lives. It's projected we'll probably be at 200,000 or 300,000 by the end of the summer. We have ways of, we can do suicide prevention. The domestic violence is a huge issue, and I don't think enough work's being done on that. Cancers, waiting a month for that. We actually have opened here in Illinois, so you can get a cancer screening if you need to. You can get a lot. For a while there, people who needed chemotherapy, who needed surgeries, weren't able to get them, but that can happen now. And the hospitals are really very carefully screening people and taking care when they come in. The economic stuff, I think, can be dealt with. There's talk about another check coming from the federal government. There's talk about going to the idea of a universal basic income for a period of time. Some of those things we can be creative and we can deal with. A virus we can't be creative, we can't control. There is no controlling a virus except separation. And so I think things that we can change policy on and be creative on, we should be doing that. And these are preventable deaths that we can prevent. We just need to be working in those directions. And I don't think we've been putting the resources into those. So thank you. That is a very good question.
Great. Sorry, everyone. I clearly was the one frozen. So I'm one of those that also doesn't have the best internet connection always. We have a few more minutes.
There's one here about giving a hug. Hugs are gone. Hugs are definitely out. Unless you live with that person, do not hug them. I don't know if you've heard about so in Asia, they do the bowing. That's always good. When this all started, we were doing elbow taps, or they call it the Wuhan tap, where you kind of tap your shoes together, but you got to be closer than 6 feet to do that. So I would say no, air hugs. That's as good as we can get now. And it doesn't matter if they live down the block or if they live, in another state. If you don't live together, you don't know what they're doing. Should people get antibody testing? So that's a really good question. I think eventually we all will. My father just did this because he had a really bad case of the flu back in February. Really bad. And he swore he must have had it. So they live in Florida, they got the antibody testing and it came up negative. The latest we're knowing about the antibody testing is that apparently the one that's been approved by the FDA is only about 85% accurate. See, there we go, next question. So the problem with that is it's it's failing to find positives. So you might get a negative. You don't actually know that means you're negative. You might still be positive. You think you're negative, and you're going out and shedding a virus, spreading disease. So eventually, the antibody is what we're going to need, but I don't think we're there yet. Again, we're still in that prevention stage, at least for the next couple of months. Can you explain on the ethics of triage in light of current research that does not understand the pathogenesis of the now endemic disease? So I would argue that it's probably not endemic yet. I think it's still, pandemic means there's sort of a low level throughout the society that people are exposed to it, they develop an immunity, some have bad reaction, but the vast majority of people just kind of have it and it's through. So I don't think we're at endemic stage yet. We may get there. You know, some of the thinking now is this might be a lot more like the flu, where it's something you get an annual injection for and that we're sort of dealing with it on an annual basis. So the ethics of triage is, you know, who do we give the resources to? In normal times, we sort of give the most resources to the very sickest people who have the least likelihood of survival. But now when resources are limited, in a triage situation, when resources are limited, the people who are the sickest and have the least likelihood to survive will use a ton of resources, but probably still won't survive. And so what we tend to do is make them very comfortable and put them into a hospice situation where we treat their pain and we make them comfortable, but we don't necessarily give them those scarce resources, and we go to the group that's under them. So we sort of, it's a judgment on medical survival, you know, and that's that piece that I had near the beginning. Are we looking at years of life, years saved, number of lives saved, social worth criteria, all those sorts of things. And that is completely irrelevant on where this disease came from. And the best science we have is that this is a disease that was in the animal kingdom. It's a zoonoses, so it's an animal-based disease, most likely bats, and that it went to humans through the wet markets in Wuhan. There is zero evidence that it came out of a lab or that it's engineered. That is all misinformation. This is something that exists. Coronaviruses have existed in nature for a very long time, and this is evolutionary possible. It didn't require a laboratory scenario. So, but that would not change the way we triage at all.